So as the title says, I'm going to talk about MRE Elastography of the liver. Briefly, I'll give you a background. But you're all expert hepatologists over here. I don't need to give a background. And I'll talk about the technique of liver MRE elastography, the experience we have so far, and the emerging applications of liver MRE other than just quantifying fibrosis. Now, as you all know, chronic liver disease is a major health concern. It affects nearly about 1 billion people around the world, and nearly 20 to 40% of them develop fibrosis and cirrhosis, and they are responsible for more than 1.3 million deaths per year worldwide. Now, the diagnosis of chronic liver disease or fibrosis is done usually by the reference standard, which is the liver biopsy. Now, liver biopsy has a definite advantage of identifying inflammation as well as early fibrosis, and also identify those with high risk of progression. And I think the most important advantage of liver biopsy or the histological diagnosis is the etiological confirmation or the etiological diagnosis. But however, it is not acceptable by almost all patients because it causes pain, it might cause complications, and also there is interobserver variability because only 1/50,000 part of the liver is sampled. So there is sampling error which occurs, and it is not suitable for monitoring fibrosis. So there was a need for a non-invasive technique to assess liver fibrosis. Now, one of the non-invasive methods being liver function test. I'm not going into the details today because they are useful, especially in advanced cases, but for mild to moderate, they may not be very useful. Imaging has always been on the forefront for making diagnosis of liver fibrosis. Conventional ultrasound, CT, and MRI are again useful when the fibrosis is advanced or they have complications, but are not useful when there is mild fibrosis. Advanced imaging techniques, mainly MR related, like diffusion weighted imaging, spectroscopy, perfusion, dual contrast, and the new thing which is called as the T1 row imaging, they're all still investigational, have not found a clinical use. So we need somewhat more sensitive and accurate technique, and elastography has proven to be the most sensitive and accurate technique. Now, all these elastography techniques, you'll be hearing from the second speaker about ultrasound method, they measure tissue mechanical property. We use the term tissue stiffness for that. And this depends upon molecular building blocks such as collagen fibers, which is the major contributor to the tissue stiffness, and at the same time, structural organization of these fibers, the vascularity, that is the blood pressure which is coming into that organ, and any pathological changes which induces the disorganization of this structure will lead to change in stiffness. Now, let's look at liver fibrosis and collagen. As I mentioned earlier, collagen is the main building block or the matrix protein which causes stiffness. Normal liver has less than 1% of its volume as collagen, which is about 2 to 8 milligrams per gram of liver. Whereas in cirrhosis, it can go up to 30 or even higher, or maybe like half of the liver may be fibrotic tissue. And I want you to concentrate on this graph over here. If you can see at the different stages of liver fibrosis and the amount of collagen is present. Now, if you look at the early stages, the incremental stage increase in this collagen is very little. And this is very much reflected on all techniques which try to differentiate early stages of fibrosis. But the moment it becomes advanced fibrosis, there's exponential increase in the amount of fibrosis. So any technique is good for differentiating an advanced fibrosis from an early fibrosis, but it is difficult to differentiate between early stages of fibrosis. And this has been echoed in many different studies. And we know that the normal liver is very soft. I mean, most of the surgeons who are sitting over here, they know how a normal organ feels and how a cirrhotic liver feels at laparoscopy or the laparotomy. And we know that there is, as the liver fibrosis increases, the stiffness also increases with the development of fibrosis. So we believe that the increasing stiffness actually represents the increased collagen content in the fibrotic tissue of the liver. So we have basically two modality-based elastography techniques, the ultrasound-based, there are many of them, and MR-based, which is only what I'm going to talk about. It's known as MRE, or magnetic resonance elastography. Now, what does MRE does? Now, the first image which I'm showing is a conventional MR image. Here you see the liver. You get an idea that there may be a lobulation of the liver, and you do not see anything else, other information. You're getting is what is known as the signal intensities and a bit of structural information. Now, MR elastography provides you a cross-section or stiffness map, which gives you the stiffness of the tissue, and we call it elastogram or stiffness map. Along with this map comes is a scale, which is called as the shear stiffness scale, which is from 0 to 10 or 0 to 8. The purple and blue, which we can see is the subcutaneous fat over here, they are very soft. A normal liver is also very soft, like fat, subcutaneous fat. And the stiff livers are usually represented by yellow to red in range, which is about 8 to 10 kilopascals. And this shear stiffness is measured in kilopascals. What we can do is that we can put a region of interest over the entire liver, and you can sample it. And this is a major advantage of MRE, that you can sample entire cross-section of the liver as compared to a very small part of the liver with other techniques. Now, elastography techniques has basically 3 steps. What we do is that we place a passive driver over the liver and send the shear waves through the liver. And we actually image the shear waves which are going through the liver. We're using a sequence called MRE sequence. And then we produce what is called as the wave image. And I'm not going to much into the details of the technique. Using that wave information, we convert that into a stiffness map. Example shown over here is a normal liver. And as I mentioned earlier, the purple and blue means it's a normal stiffness of the liver. And this technique can be easily integrated into any clinical scanner, either 1.5 or 3 Tesla. You need an active mechanical driver, which is over here, which is kept outside the scanner room, and it is connected to a passive driver with a plastic tube. And we need an MRE sequence and an inversion algorithm done. All these are done automatically, and the moment you do the MRE, within 2 minutes, the stiffness map comes up on your console. And this is a placement of the passive driver. We place it over the right lobe of the liver because that's where the largest part of the liver is present. And we do not place it on the left lobe of the liver because we might get movement from the cardiac pulsations. Here's a video showing how we do the MR elastography. Here's a patient simulated in the scanner room. And as you can see, that the passive driver is kept over the right lobe of the liver, and shear waves are produced in the passive driver and goes through the liver. This actually goes through the entire liver. And imagine we are taking one single slice through the liver, and this is how it would look. Now, the shear waves going through the liver causes shear wave movement. And mind you, this is an exaggerated cartoon. You know, shear waves do not go that big. This is exaggerated because the movements are usually in micron level or nanometer levels. And if you look at a stiff liver, which is like a hard cardboard, if you try to shake it, it will actually move very little, and you can see the waves going through very fast and long waves through it. And the beauty of MR elastography is that you can actually measure or visualize the shear waves going through these livers, as shown in the image over here. That the normal liver, you can see that the waves are smaller compared to the stiff liver, which is the waves are longer, and it is converted into a stiffness map as a normal liver over here and a very stiff liver over here. Here's another example of a normal liver and a stiff liver. I can see here the wavelength or the shear waves going through the liver are smaller compared to that which is longer in the cirrhotic liver. And we have also seen that as the stiffness of the liver or the stage of the fibrosis increases, the wavelength of the shear waves going through the liver increases, and this is reflected as we see over here, the change in the color of the liver in the stiffness map from blue, purple to going to green to orange, and finally to the red. This is in contrast to a normal liver, which is usually purple and blue in color. And normal liver is usually less than 2.5 kilopascal, and liver, as you can see over here, it is 10.8 kilopascal, which can go up to 20 to 30 kilopascals if it is very severe. And our experience has been growing with MRE for the assessment of the liver stiffness. And here's an example showing about 450 patients with biopsy less than 1 year, and we can see that the stiffness increases as the stage of the liver fibrosis increases. And this is a group of patients with mixed etiology. So we've also there are also publications with single etiology, as I show over here in the chronic hepatitis C, hepatitis B, alcohol, and non-alcoholic fatty liver disease. Again, the same trend is seen. But I want to mention to you again earlier that I mentioned about the collagen fibers content deposition is very minimal between early stages, but it becomes high as the stage of fibrosis becomes advanced or becomes cirrhosis. And this is reflected on almost all kinds of etiology, and it is very important to remember why these techniques may not be accurate when you are trying to differentiate between early stages of fibrosis. And we also proved that MRE stiffness correlates with the collagen content, which we found with the biopsy specimens. This is a new technique called the Fibrosis index, where we actually quantified the amount of collagen within the tissue samples, and we correlated with the MR elastography stiffness. and this correlation was quite good, about 0.8. Again, note that the dots are not on the line as you go towards the increased fibrosis, because it's very heterogeneous and there is sampling error from the liver biopsy. MRE is a highly repeatable, reproducible test. What I mean by repeatable is if you make the patient get out of the scanner and come back and lie on the scanner, and if you do it, you'll get the same result. What I mean by reproducible is that if two different radiologists measures this liver stiffness, the liver stiffness is likely to be reproducible within a standard deviation of 10%. In fact, the Interobserver correlation is very high, about 0.93 or 93%. The major advantage of liver is that you can perform in obese patients. This is a patient with a BMI of 45. As long as the patient fits into the MR scanner, you can do an MRE. If the patient does not fit in the MRE scanner, you cannot do it. Even you can perform MRE if the patient has ascites. Now you might question, why do we need to do in a patient with ascites? So let's say the patient has an ascites for another reason, you cannot do biopsy in this and the first initial presentation, then you can still do MRE in these patients to know whether the liver is fibrotic or not, as in this case. And even in the presence of catheters or any kind of catheters or any instruments, as long as they're MRI compatible, you can perform MRE in these patients. And one important advantage is that the fatty change in the liver does not affect stiffness. Here's an example of the graph showing the different patients having different amount of fat in the liver and the liver stiffness. You can see that there is no correlation between the liver stiffness and the fat. And this is a major advantage because we do not want fat to come in the way of our evaluation of liver stiffness or the liver fibrosis. In fact, we have seen differences that simple steatosis does not cause increase in stiffness, whereas steatohepatitis causes mild increase in the stiffness, and of course, if you have steatohepatitis with fibrosis, it will go higher. So we can actually differentiate simple steatosis from NASH with an accuracy of more than 90% with using MRE. And the MRE experience has been growing ever since the first publication in 2006 by the Mayo Clinic, where the accuracy was 100% with a very small number, and now we can see that the accuracy is still in the 90s. I would say safely it is more than 90% to differentiate normal liver from any fibrotic liver, and when it comes to significant fibrosis, the accuracy is more than 95%. We also performed a recently systematic review and a meta-analysis with multi-institutional studies. We combined about 700 patients from 12 studies, and we also showed the same thing, the accuracy for differentiating normal from any kind of fibrosis was 0.84, and it gradually increased as the liver fibrosis stage was increased. It's like advanced fibrosis has 93% accuracy. And MRE has been shown to be superior to other techniques such as the liver function test, FibroScan, and even using morphological features on imaging, diffusion-weighted imaging, IVIM, which is a new form of diffusion-weighted imaging, even gadoxetate, or now here it is known as Primavist, and MR spectroscopy, and all these cases have been shown that MRE is better than all these tests. Here's an example which is from my own publication over here. We did it with chronic hepatitis B, and we've shown that the MRI outperforms all kind of simple liver function tests. We didn't do any specific hyaluronic acid or anything. We mainly did was APRI, AST-ALT ratio, prothrombin time, and ALT levels, and it was shown that MRE was much better than these simple liver function tests. And important contention, I think everybody would be wondering, how does MRE fare with comparison to transient elastography or FibroScan? Now, the basic technique difference is that the FibroScan samples only about 1/500th part of the liver, but with MRE, potentially we can scan the entire liver. And you can see that there's quite a bit of an overlap with the FibroScan stiffness, which is measured with the transient elastography as compared to that with the MRE. And this difference is particularly obvious when you do mild fibrosis. You can see that the accuracy of MRE is much better when you differentiate mild fibrosis, whereas as you go with advanced fibrosis and cirrhosis, the accuracies between the FibroScan and MRE are comparable. So if you want to diagnose an early fibrosis, MRE is probably the better bet than FibroScan, especially given that the FibroScan may fail in 6 to 10% of patients, and also if you have an obese patient. MRE has been shown to be better than RFI, which is another new technique with ultrasound-based technique. And you can see that the accuracy is better than RFI, as in shown in this meta-analysis. It is also better than shear wave elastography. I believe you'll be hearing about shear wave elastography soon in the next talk. And we also seen that the shear wave elastography had significantly higher unreliable test results compared to the MRE. In this particular study, it failed in about 13% of the patients, and which can be quite substantial, especially if the patient happens to be obese. MRE is not a perfect technique. The current MR elastography technique is 2D based, or two-dimensional gradient echo based, which is sensitive to the presence of iron in it. If the iron content is high, the MRE will fail. As shown over here, this is the conventional GRE based MRE technique, and you can see that the stiffness map is not interpretable. But we have come up with the solutions. These are research scans. We have come up with different techniques to improve the signal in this iron overload livers in order to increase the signal. Mind you, the technique failure is not because the shear wave does not go. The shear wave does go through the liver. It's just that the shear waves cannot be seen because of the low signal coming from the liver. You also should know that the liver stiffness is not just caused by liver fibrosis, even acute inflammation. If the patient has an acute hepatitis, it will cause increased stiffness. Any kind of acute biliary obstruction secondary to stones or any other cause can give rise to increased liver stiffness. Passive congestion secondary to cardiac failure or acute venous occlusion, such as in Budd-Chiari syndrome, can also give rise to increased stiffness. Portal hypertension. Now, almost all of you are here are postprandial, and if your livers are normal, there will be no increase in stiffness, but if your liver is fibrotic, your liver stiffness increases postprandially within about 30 minutes time. And if you have diffuse metastasis, which is very rare, you can also have increased stiffness if you don't see a particular lesion in them. So other clinical applications which we are now seeing at the Mayo Clinic are this one, is to assess treatment response. We started MR elastography in 2006 at the Mayo Clinic, and now we are seeing patients coming back as a follow-up. These are two patients with chronic hepatitis C, both having similar liver stiffness of 4.2 kilopascal, which would be, by using our classification system, at least stage 3 fibrosis. Both were on antiviral treatment. This patient comes back 3 years later. His stiffness has improved to 2.8 kilopascals. Now you will see, if you see that there is no change in the liver appearance, but the stiffness has improved. Whereas in this unfortunate patient, the liver stiffness actually increased to 6.3 kilopascal. He unfortunately progressed, and within another year time, his liver stiffness became 10 kilopascals. So this is a natural progression history and not responding to the antiviral treatment, and you can actually monitor them without doing a liver biopsy by just showing the increase or decrease in stiffness, whether they are responding or not responding. Now, what happens in those cases where you don't have a particular treatment method available or a particular treatment option, such as this case with the primary biliary cirrhosis? We were monitoring these patients for every year so that we want to find out if the patient develops fibrosis. So in 2010, had 2.8 kilopascals, and it increased gradually to 3.4 kilopascal in 2 years' time. And this year, as you see, the liver looks the same throughout all the 3 years with no changes in the signal intensity. What I want to highlight is that MRE can detect fibrosis even if there is no change in the liver appearance or no nodularity is seen. And this is a new development we also found out with our review of our cases. We actually could find out that we can predict decompensation in a compensated liver by using liver stiffness. We found out that using a cutoff value of 5.8 kilopascal in patients with compensated liver fibrosis has a hazard of decompensation of 4.96 for patients who had these as compared to those who had lowest liver stiffness value. So MRE may be useful for prognostication as well if you do it as a baseline investigation. As I mentioned earlier, liver stiffness in fibrosis is quite dynamic. That is, we have two components, which is the static component, which reflects the structural changes of fibrosis within the liver, and a dynamic component, which reflects the portal pressure that can increase after a meal. Here are two examples. This is a normal healthy volunteer. After giving a standard meal, there is no increase in the liver stiffness, which is about 2.2 kilopascals. Whereas a patient with fibrosis stage 4, from 8.5, it increased to 12.73. This is because there is increased flow in the portal vein that actually distends the capsule, and that the fibrotic liver does not have a normal homeostatic mechanism, whereas the normal liver has a response system which dilates the sinusoids and reduces or keeps the pressure the same. So this can actually be used to an advantage to make a diagnosis whether patient will have portal hypertension chances or not. We can also do MR elastography of the spleen, and using a cutoff value of 10.5 kilopascal, we have shown that it is predictive of bleeding esophageal viruses. And this is very easy to perform, as we will be putting the driver over the spleen. Recently, we also found out that with the distribution of the stiffness, we can actually look at some of the etiologies. This is an interesting development over the past 3-4 years. You can see that these are different etiologies and all are biopsy-proven liver cirrhosis. Hepatitis C, primary biliary cirrhosis, primary sclerosing cholangitis, and autoimmune hepatitis. Particularly focus on the primary sclerosing cholangitis. You can see that the stiffness is peripherally distributed as compared to the other etiology, and we think this occurs in mild to moderate cases or early cases of primary sclerosing cholangitis, and this may prove to be an important diagnostic marker for making a diagnosis of primary sclerosing cholangitis. And lastly, I'll be talking about the one thing which is going to come up is that we can do 3D. What I mentioned about is a two-dimensional technique. This is a three-dimensional technique where the entire liver can be assessed with stiffness, and I'm introducing the term what is called as liver fibrosis burden. So you might actually know the entire liver, how stiff it is, and you can make an assessment whether the liver can go for decompensation or not. And these are still early stages, but we'll be coming up with the results soon. This was my project when I was a fellow doing as a focal liver masses, and we found that the benign tumors such as hepatic adenoma and focal nodal hyperplasias are softer as compared to cholangiocarcinomas, hepatocellular carcinomas, and colorectal metastasis. In fact, in that publication, we showed that if we use a cutoff of 5 kilopascal, it accurately differentiates all malignant masses from benign masses, except there's complex hemangiomas which are fibrosed. Because they are fibrosed and stiff, they cannot be differentiated, but there was an accuracy of 100% of differentiating malignant from benign tumors. So the last slide is about emerging indications for MRE. We have found that the surgeons are more interested in finding out the liver stiffness before they resect the liver, because they don't want to encounter mild fibrosis in these patients. And post-chemotherapy, especially for colorectal metastasis, they are at risk of developing NASH, steatohepatitis, and fibrosis. And oncologists are concerned, and they want to find out if the liver is soft or fibrotic. And even recurrence of fibrosis in transplants is also a new indication for MRE. And also, interestingly, we did find out that liver donors can have silent fibrosis, especially when they have fat. And we are now doing routinely MRE elastography in all donors in order to detect if they had any fibrosis. So in summary, MRE is an accurate and reproducible technique for evaluation of liver stiffness. And MRE is useful for clinical follow-up as well as assessment of treatment response. And I think, in my personal opinion, MRI with MRE will give a comprehensive assessment of chronic liver disease, because you're giving evaluation of fibrosis, fat content, iron, and as well as looking at the complication. So I started with this slide as a new kid on the block, but I do not agree that it is a new kid on the block. Probably it will be the new reference standard for quantifying liver fibrosis. Thank you.